Welcome to this video on the pathology of drowning, covering medico-legal principles, pathophysiology, and diagnostic imperatives. The primary definition of drowning is asphyxia from fluid aspiration. Critically, complete submersion is not necessary. Diagnosis is often one of exclusion, relying on a constellation of evidence, as findings can be minimal. Drowning is classified into 4 types. Dry drowning involves no water entering the lungs, causing immediate laryngeal spasm. Wet or primary drowning involves water inhalation leading to cardiac arrest. Immersion syndrome is immediate cardiac arrest from vagal inhibition. Secondary drowning involves delayed complications after survival for over 24 hours. Freshwater drowning causes massive hemodilution. The hypotonic water absorbs into the blood, leading to hypervolemia and massive hemolysis. This results in ventricular fibrillation and rapid cardiac failure within 4 to 5 minutes. Seawater drowning causes lethal hemoconcentration. Hypertonic seawater draws fluid from the blood into the lungs, leading to severe pulmonary edema. This results in massive hemoconcentration, hypernatremia, and ultimately slow death from myocardial anoxia and asphyxia in 8 to 10 minutes. The drowning lung appearance differs significantly between fresh and seawater. Freshwater lungs are ballooned, but light and pale pink. Seawater lungs are ballooned and heavy, with a purplish or bluish color, soft and jelly-like consistency. Drowning froth is a key external sign. It forms from inhaled water, mucus, and surfactant, combined with violent respiratory agitation. Its presence, highly characteristic of drowning, appears at the mouth and nostrils quickly and resists collapsing. Environmental dermatologic reactions include washerwoman's hands and feet caused by water absorption and, cutis anserina, or goose skin, a spasm of the erector pilae muscles indicating the body was submerged while muscles were still irritable. The cadaveric spasm, the drowning man clutching at a straw, is forensically significant. If aquatic vegetation or foreign materials are firmly grasped in the hands, it proves a violent struggle and that the victim was alive upon entering the water. Internal autopsy findings include the emphysematous lung. Cardinal signs are emphysema aquosum, lung ballooning, and visible rib impressions left on the lungs by the rib cage. Paltaf's hemorrhages are subpleural ruptures of the alveolar walls, present in about 50% of typical drowning cases. They are caused by the tearing of the alveoli due to overdistension, violent respiratory efforts, and the check valve effect of the froth. Cranial and oral barotrauma is due to hydrostatic pressure compressing air in closed cavities. This can cause middle ear hemorrhage, present in roughly 50% of cases, and hemorrhage in the mastoid air cells. Biochemical diagnostics include serum strontium, the modern standard, which is effective for differentiating antemortem drowning from post-mortem immersion. Other tests include plasma-specific gravity and the historical Gettler test. The Diatom Journey provides proof of circulation. Diatoms are microscopic algae inhaled in the drowning fluid. An actively beating heart is required to pump them from the lungs into distant organs like the bone marrow, providing proof the victim was alive in the water. Diatoms have various morphologies and sizes, ranging from 10 to 80 microns. They are extracted using direct digestion, where strong acids dissolve human tissue but leave the indestructible silica diatom skeletons intact for identification. Medico-legal circumstances for a body recovered from water are typically categorized as accidental, homicidal, or suicidal. Accidental is the most common, often involving domestic bath collapse or hyperventilation death. Interpreting aquatic trauma requires distinguishing between pre-immersion injuries and environmental artifacts. Pre-immersion injuries, like head trauma, complicate the diagnosis. Post-immersion artifacts include mechanical abrasions and biological attack by aquatic life.
The diagnosis of exclusion uses a weight of evidence scale. Tier 1 includes fleeting signs, like froth. Tier 2 contains robust signs, like middle ear bleeding. Tier 3 includes incontrovertible proof, such as cadaveric spasm and diatoms.
The forensic checklist for drowning relies on cumulative evidence, not a single feature. Reliable signs include the characteristic froth, cadaveric spasm, voluminous lungs, presence of the drowning medium in the stomach, and extraction of diatoms from distant tissues.